Hi there, Dr. Commissaris here. I was working on a lecture for the neuromodule, and I made a very interesting discovery in my office. So there's the wastebasket in my office, and it turns out that someone had thrown away a lecture. Let's see what it's about. Oh, it's a lecture on the DSM-5. Supposed to be in the neuromodule, but now it's in video form. Well, let's take a look at what's in this lecture. Interesting. It appears that the lecture had some goals and objectives. One was to familiarize the students with the recently updated version of the Diagnostic and Statistical Manual of Mental Disorders, DSM-5. Also to describe some of the historical developments over the course of the various editions of the DSM. And describe how some of the changes in DSM-5 compare to its predecessor, DSM-4. And then finally to compare the DSM-5 to the ICD-10. This could be very interesting stuff. Very interesting indeed. Oh, this is a very busy slide. This is the history of the DSM. Must have a rich and important history. Well, it looks like it comes from the APA, the American Psychiatric Association. The first one was in the 1950s as a result of World War II and some of the disorders that people were suffering from after World War II. In 1968 it was revised. In 1980 it was revised again. It was revised moderately in 87. Another revision in 94. Boy, this thing's get changed a lot. Updated again in 2000, and then in spring of 2013, only a year ago, DSM-5 came out. Now, one thing that's interesting, it's a little bit weird too. DSM-5 is the Arabic numeral, not the Roman numeral. Why they changed that, it's not completely clear. But the DSM-5 is the current version. This is just exciting stuff. You're probably wondering, well, so what's the purpose of the DSM-5? Well, the DSM-5 and the purpose really comes from the DSM-4, so pretty much the same from before. Provides clear descriptions of the diagnostic categories in order to enable clinicians and researchers to diagnose, communicate, study, and treat people with various mental disorders. But it doesn't really have treatment guidelines. When it says treat, it really doesn't talk about particular treatments. Again, from the DSM-4, allows for the collection of basic mental health statistics for research purposes. So you'll see a lot of papers in Archives of General Psychiatry, if you look in there. You'll see papers that say, patients met the DSM-5 criteria for, and they'll tell you the disorder. And lastly, it's the official diagnostic and classification tool in the U.S. It's widely accepted in Canada. And so basically that's about it. That's the DSM-5. And this is it. Reality is, it's a purple book. So what are the basic features? Well, it has a descriptive approach. It attempts to describe comprehensively what the manifestations of the mental disorders are with no regard to cause or treatment. It just describes them. And it provides diagnostic criteria in those descriptions. It sort of gives you a checklist, and it sort of says, well, here are the things that you might have if you have primary depression. If you have 4 or 5 of these, then you might have primary depression. It's kind of a checklist, kind of an approach. Those are the basic features. Oh, apparently it has more basic features. It has the systematic description. It systematically describes each disorder in terms of its essential features and associated features. Some of the comments about the other factors like age, onset, course, degree of impairment, complications, things like that. It provides some diagnostic uncertainties, and it provides guidelines in terms of a cautionary statement. And I'll give you that cautionary statement because I think that's in this document too. So here's the cautionary statement. Basically, it's in the DSM-5. And what does it really basically tell you? This is from the DSM-4, but it's in the DSM-5 too. Reading this book does not make you a psychiatrist. This document is not the final say regarding every and all psychiatric condition. If you know someone with some of these traits, it does not mean that they have the disorder. And finally, this book is not to be used for non-medical purposes, for insurance and legal kinds of issues. It probably will be. Its predecessors have been, but the disclaimer says it's not supposed to be. So that's the cautionary statement. So you might ask, well, how is it different from DSM-4? Well, here's a way that it's different in a kind of a big way. The DSM-4 had this what was called a multiaxial assessment. It's not really part of the DSM-5. So the DSM-4 had this multiaxial assessment, which essentially involved assessment of severe system or problems instead of a single presenting problem. Each of the 5 axes refers to a different domain of information that may help plan treatment or predict an outcome. For example, axis 1 was like the main clinical disorder with the diagnostic criteria. Axis 2 was about some overriding, superseding kind of personality disorders or mental retardation conditions that may affect the patient. Axis 3 was about general medical conditions. Does the patient have unmanaged hypertension, unmanaged diabetes, those kinds of things. Axis 4, psychosocial and environmental problems. Did the patient just lose their job? Did they just have a baby? Did they just get a divorce? Some of the psychosocial and environmental problems. And Axis 5 was kind of the global assessment. Give me a score from 0 to 100 and tell me how is this patient doing based upon all these different axes. So with the old-time multi-axial assessment, the patient would have like a one-page write-up here where just sort of provide information on how they're doing on each of those 5 axes. And that was sort of the written assessment that the psychiatrist or the psychologist would provide when assessing the patient. But DSM-5 does not have multi-axial assessment, at least not formally. What it has done, it sort of captures some of the same stuff. Axis 1, 2, and 3 from the DSM-4, they've collapsed them all through into a single diagnosis list that includes diagnoses previously listed in Axis 1 and 2, along with some of the other 9 psychiatric conditions. In place of Axis 4, it uses the more formal V and Z codes from ICD-9 and 10. We'll talk about ICD-9 and 10 in just a little bit. And instead of Axis 5, sort of the overall performance on a 1 to 100, 0 to 100 scale, they use the World Health Organization Disability Assessment Schedule, the WHODAS. Basically, it is still multi-axial, but it's not really called formally multi-axial anymore. It captures the aspects of the multi-axial assessment. So what are some of the criticisms of the DSM-5 and also criticisms of its predecessor, the DSM-4, in its revised version? One of the criticisms is it's not empirical enough. That is, it's really not based on EEG stuff, it's not based on blood tests or any kind of performance measures. It's really based on answers to questions as asked by psychiatrists or psychologists who are trained in the area. And some don't think that's empirical enough. In some situations, it's argued that it's not used consistently by all the experts. I mean, that goes back to essentially different people will interpret how you ask the questions and how you deal with the answers differently. It's argued that it's based on Western cultural assumptions, and it probably is. It's argued that it's used by non-professionals to make categorizations as well. Insurance companies make decisions based upon DSM that really aren't what DSM was intended to be used for. There are arguments that there's a personal conflict of interest, primarily a financial interest. That is to say, the authors of the DSM-4 and the authors of the DSM-5 both were pretty well connected with the drug companies, and there's always a concern that they're advocating for a particular disorder to have a particular place in the DSM document because of the royalties they're getting for speaking on behalf of the product that is used to treat that disorder. I think that's it's hard to demonstrate clearly, but I think there's some very serious concerns for that nonetheless. Another criticism is not guided by any real theory or construct regarding how the normal brain works. I mean, I'm not just talking about norepinephrine pathways and dopamine pathways. There's a tremendous amount of work that's been done in terms of how neurocytoarchitecture and how the brain might function as sort of an engineering machine of sorts. And there's really not much appreciation of that in the creation of the DSM-5. It doesn't mesh with that at all. And the last criticism is that some cynics would say it's guided by a need to create diagnostic categories in order to obtain treatment for the patients. again, that goes back to support from pharmaceutical companies. If you want to read more about some of the criticisms of the DSM-5 and a little bit of history in terms of how it came to be, I'd recommend this book called The Book of Woe. It's a bit of a historical as well as a novel kind of a thing. Gary Greenberg is a psychologist who uses the DSM-4 to deal with patients that he interviews. He was rather negative about it, but it's a very readable, very interesting story in terms of how it came to be. And I would recommend that for anybody who's really interested in it. So I mentioned the ICD-9 and 10 earlier. ICD is the International Classification of Disease. That's the ICD, International Classification. It's the International Standard Classification for all general epidemiological and many health management purposes and clinical uses. These include analysis of general health situation of population groups and monitoring of the incidence and prevalence of diseases and other health problems. Basically, the ICD is the international cover-all for these diseases and disorders. ICD is not limited to the brain. ICD includes everything. ICD is the international version. It was endorsed by the 43rd World Assembly, and ICD-10 was endorsed by the World Assembly in May 1990, and really came to be a World Health Organization member states in 1994. So this is basically the gold standard for everything for all the world. So the question might be, how does DSM-5 fit with the ICD? That's a little more history of the ICD, but basically ICD-9 was published in 1979, and basically ICD-9 and DSM really sort of came into line at that point. They were quite comparable, but there are ICD categories and DSM categories that are virtually the same. And the 10th revision of the ICD was revised in conjunction with the DSM-4, so there really was essentially a lot of agreement, and there probably will continue to be a lot of agreement between the DSM and the ICD. Well, the primary function of the ICD originally was to outline categories to simplify the collection of basic health statistics, and some of the uses of the ICD since its original inception. It facilitates the collection of basic medical statistical information to generate reports. The World Health, U.S. Health Financing Administration essentially uses this to create the codes and list the codes for reimbursement. And ICD is mandated under the Medicare system. As I said earlier, ICD, the scope of ICD is to cover everything, not just brain things. DSM-5 covers only psychiatric, mental disorder kind of issues. They are very good agreement now. They weren't initially when the DSM and the ICD were sort of in their infancy, if you will. But right now they're in very good agreement. One very big difference is the ICD is free. I believe it's available online. DSM is not free. This slide just talks a little bit about some of the things that have happened, sort of the evolutions in DSM across different editions. The first edition was sort of developed as a consequence of World War II and trauma related to World War II by a lot of individuals. And DSM-2, by the time in the 60s when it was created, sort of dropped the whole reactionary kind of a component to it. The sort of reaction was dropped. In 1980, when DSM-3 came out, there was a movement to sort of become way more empirical. And so rather than talk about this, that, and the other thing in the history, sort of less Freudian, it became, tell me the symptoms. Give me the list of symptoms, and if it matches the list of symptoms, then you have reason to suspect that they have that disorder. DSM-4, when it came out, really emphasized distress and impairment of functioning. So it wasn't enough to meet the symptoms. You had to meet the symptoms, and it had to be related to impairment of your life and your function in your life. And the DSM-5 just a slight movement away from checklists, and really sort of just, again, continues to emphasize patient impairment as the main issue. I'll give you one example of changes in the DSM to show how it's sort of a fluid document. The issue of sexual orientation and homosexuality. In DSM-1, homosexuality was listed as a disorder. In DSM-2, there was a sexual orientation disturbance. In DSM-3, they created something called the ergodystonic homosexuality disorder. In 3, it was later revised so that the sexual disorder not otherwise specified was met only if there was a persistent marked distress about one's sexual orientation. Homosexuality by itself was not listed as a disorder per se, and that was continued in DSM-4. And in DSM-5, it's continued to move in that same vein, similar to the DSM-4. There's a thing called a gender dysphoria, which basically it relates to patients struggling because of gender changes. But the issue of homosexuality is no longer directly a part of the DSM. There are some other changes in DSM-5 relative to DSM-4. One is that Asperger's is not a specific disorder. You could view this as to say there will never be another Asperger's patient diagnosed again, because Asperger's is now part of the larger autism spectrum, and it's not a separate subcategory. The psychiatrist Asperger in Australia is probably a little upset that his name's been taken off the books, but that's the way it is. Another thing that I think most people would be very appreciative of, and we're much in agreement with, was the bereavement exclusion has been eliminated. What that means is that in all previous versions of the DSM, even the DSM-4, if a person suffered depression because of the loss of a loved one, that was not considered depression, because it was bereavement, and that was an exclusion kind of a thing. In DSM-5, there is a clear recognition that loss of a loved one can result in real, lasting depression that can require real treatment. A couple of changes went into effect in DSM-5 that will affect some of our lectures. OCD, obsessive compulsive disorder, and post-traumatic stress disorder, PTSD, have been removed from the anxiety disorders section. We'll talk about that a little bit later, but basically they've been removed. They're not out of the DSM. They're just in different categories now. Hoarding disorder has been added. I guess the cynic would say that's because the writers of DSM-5 have been watching cable TV just like a lot of other people. Another change is with respect to intermittent explosive disorder. I think there was a lot of debate about this. In the DSM-4, an individual could not be diagnosed with intermittent explosive disorder unless they had a short fuse and they actually physically assaulted someone. With DSM-5, physical aggression is not required anymore. If you verbally assault someone in a very aggressive way, that can lead to the categorization of intermittent explosive disorder. And there are a few other changes, but those are sort of some of the major changes in DSM-5. Well, to summarize, the DSM has been in use in 1952. It is for psychiatric disorders only, as opposed to the ICD. It's widely used in the U.S. and Canada. It's pretty good with agreement, very good agreement with ICD-10 today. It does not include information regarding the cause of the diseases and/or the treatment approaches. And even though it doesn't have specific treatments, some have still argued that it might be some of the classifications, the creation of new classifications, has been driven by the market and the ability to treat something with a particular drug. If there's a drug to treat it, we want to give it a name so that when the clinician sees the patient, they can give it that category of name, and then they can justify that drug. That's sort of the cynic's argument there. I'm not sure whether reality falls on that, but that's sort of the argument. So the goal here for this lecture was to familiarize students with the recently updated DSM-5, describe some of the historical developments over the course of various editions of DSM, describe some of the most recent specific changes in DSM-5 compared to DSM-4, and compare and contrast DSM-5 and ICD. I think we've met most of those goals and objectives. I see that our wastebasket is now empty, so I guess you'll have to return to your normal programming. There's just not much to see in here. No matter how much you zoom in, there's just not a whole lot of detail in there. It's just a wastebasket. Anyway, goodbye from the waste bin of the neuro module.